So let's just discuss today about the prostatic cancer, because in the last lecture we have been discussing about the benign prostatic hyperplasia. So in the prostate, there are two things which are very much important. One is the benign prostatic hyperplasia we have covered in the previous lecture, and other is the prostatic cancer. So today our main focus would be on the prostatic cancer. If you look at this diagram, you can see here, the prostate is related to the rectum because of this relationship, because when you're performing the digital rectal examination, you can actually go and palpate the prostate gland rectally. So you can see the rectum is located posteriorly to the prostate, and the bladder is located in front of the prostate. And if you go for the digital rectal examination, because of this anatomical relationship of the prostate with the bladder and with the rectum, you can actually go and palpate the surface of the prostate, which is very much likely to be nodular in case of the prostatic cancer. So if we talk about the different type of like the pathological factors which are responsible for the prostatic cancer, we'll be discussing each one by one. Actually, if we talk about the pathophysiology of the prostatic cancer, we know that the prostate is a gland which is composed of different kinds of the duct and the acini. And most of the time, because of the glandular appearance of the prostatic organ, actually this is the carcinoma is the adenocarcinoma. But if we talk about the pathology of the prostate gland, it can be, some of the prostatic cancers, they're very small in number, the patient remain symptomless, and you incidentally find out that there is a prostatic cancer, and the patient will not be symptomatic if the cancer is in the earlier stage. So pathologically, there can be microscopic latent cancer, which is found on the autopsy or the cystoprostatectomy. And tumors are also found incidentally, like when you're performing the TURP, there can be T1A and the T1B tumors. I'll be discussing, this is the T1A and the T1B. This is basically the TNM staging, and we'll be discussing like which stage is T1A and T1B, and what is the invasion of the prostate. And then what you do is you follow the cancer screening by the prostate sensitive antigen, and there can be early localized prostatic cancers, which are T2. There can be advanced local prostatic cancers, which can be T3 and T4, and some of the clinically evident tumors like T2, T3, and T4, and obviously the metastatic tumor. So actually, starting from the microscopic latent lesions, which you can found in transurethral resection of the prostate in case of the benign prostatic hyperplasia. So I will be discussing the TNM staging for the prostatic cancer later in the presentation. But if we talk about, we know that actually the pathophysiology of the cancer cells is like the positive family history, some kind of the mutations in the p53 genes, which are the tumor suppressor genes, and whenever there are mutations, obviously the phagocytic activity of the cancer cells are basically the phagocytic activity is decreased, and because of that there is a development of the full-blown cancers, and the cancer cells, they have the increased mitosis, and because of that a full-blown carcinoma develop. But in case of the prostate cancer, let me tell you that this is the most important and the most common cause of the cancer in a man over the age of 65 years. It is the first leading cause of the death in the older men. So you should always keep in mind that the prostate cancer is usually the cancer of the old age, and whenever you're suspecting like the colonic cancer, we have discussed the colonic cancer in one of the previous lectures. So like the colonic cancer, prostatic cancer is also a cancer of the older people, but it can be found out to be in the younger men as well, younger patients. But the more aggressive tumors are in the younger people, and less aggressive tumors are in the older people. But always think about the prostatic cancer whenever the patient is coming to you with a decreased urinary output, or acute urinary retention, or different kinds of the obstructive symptoms, like obviously when there's a prostatic cancer, actually it's compressing the prostatic urethra, and there's a backflow of the urine, and because it's not going further because of the obstruction or the increased size of the prostate gland. So keep all these things, that the prostatic cancer can be incidental finding, and there can be early development or localized cancer like T2 stage. There can be advanced cancers like T3 and T4, and the metastatic cancer as well, because most of the time it's the Batson venous plexus which ultimately lead to the development of the metastatic cells into the bony part. And most of the time the lesions on the prostate cancer, these are osteolytic lesions. Now let's just talk about a little bit about the histology of the prostate cancer. We actually know that the prostate is a gland. So whenever there is a glandular structure, there's some kind of the acini and the ducts. You can see here in the picture that these are the glands, and the other cells you can see here with the purple discoloration, they are actually the stroma. And in case of the prostatic cancer, this is actually the stromal part, or the rapid division of the myoepithelial cells. So glands are actually, in case of the benign prostatic hyperplasia, there's a glandular hyperplasia and there is a stromal hyperplasia as well. But in case of the prostatic cancer, these are the acini and the glands which are located with the ducts in the center, and they're surrounded by the myoepithelial cells. So in case of the these are the adenocarcinomatous cells in case of the prostatic cancer. So you can appreciate in the diagram the different kind of the glandular cells and the myoepithelial hyperplasia, which you can see as the purple or blue dots which are visible in the diagram. So this is important to know, that how the prostatic cancer is spreading. Actually, there are three. Whenever we talk about a cancer, we know that there are three means for the spread of the cancer. One is the local spread, the other is through the lymphatics, and the other is through the bloodstream. So if we talk about the local spread of the cancer, you can see here that this is the part of the prostate gland, and this is the tumor which is present here. So if we talk about the local invasion or the local spread of the tumor, we know that it is kind of related to the seminal vesicles, and also it is related to the neck of the bladder. So most of the time, if we talk about the local invasion, the tumor is invading the seminal vesicle, and obviously the trigone of the neck, a trigone in the neck of the bladder. Plus, there's also local invasion to the surrounding structures. Like there can be invasion to the rectum as well, because they are related to one another anteriorly and posteriorly. So if we see in the diagram, this is the local spread, and the kind of the local invasion actually breaching the capsule of the prostate gland and then entering into the surrounding structures. The other type of the spread in case of the prostatic cancer is the lymphatic spread. We know that the prostate is actually draining into the ultimately draining into the internal iliac, those lymph nodes which are just close to the internal iliac vessels. So you can see here, these are the different kinds of the lymph nodes which are being metastasized, and ultimately it's involving the local lymph node nodes and then spreading far distally up to the internal iliac. And if that was about the lymphatic flow. But if you talk about the bloodstreams, and there can be through the bloodstream, that we have a Bateson venous plexus, and this Bateson venous plexus is actually responsible for the connection of the pelvic and the thoracic veins to the veins of the vertebral column. So that is the reason the breast cancers, because the breast is draining into the thoracic veins, and the internal thoracic, and also so because of that drainage, it goes to the vertebral column. So the prostate metastasizes to the bony vertebral column. So the most common sites for the metastasis of the prostatic cancer is the lower lumbar vertebrae. There can be pelvic bone invasion. There can be metastasis to the ribs, and the other, if we talk about particularly the ribs, as well, and the lumbar vertebra most commonly, and the femur as well. So always remember the 4 sites for the invasion of the prostatic cancer, like lower lumbar vertebra, then ribs, and then pelvic bones, and then obviously the femur. And the most common pathway for the prostatic cancer spread is through the veins, and ultimately it's involving the vertebral column, because the Bateson venous plexus is the plexus which is connecting the pelvic veins to the veins in the intervertebral column. So that is the reason, that is the root of the spread of the prostatic cancer into the vertebral column. So always remember 3 important pathways for the spread of the prostate cancer. One is the local, the other is through the lymphatics, and the other is through the vasculature, like the bloodstream, right? So local spread is involving the seminal vesicle, the rectum, or the part of the bladder as well, neck of the bladder and the trigone, and lymphatic is spreading up to the internal iliac, and the most common and important is through the bloodstream, through the Bateson venous plexus. It is involving the vertebral column, especially the lower lumbar vertebra, plus the femur and pelvic bones, and obviously the ribs as well. Now this is something very important to stage the cancer. So T0, T1, T2A, T2B, T3, and T4. So this is the TNM staging. We'll be discussing about this. T stands for the tumor, like it's telling about the invasion of the tumor. N is the nodal status, and M is the metastasis. So if we talk about like the T0, T0 is like there's no tumor. T1 is further divided into T1A, T1B, and T1C. So this T1A, T1B, and T1C, the tumor is symptomless. The tumor is not invading, and you cannot actually, the patient is symptomless. So the finding of this tumor is incidental whenever you're performing the TURP, transurethral resector of the prostate, in case of the benign prostatic hyperplasia, and then you send the specimen for the biopsy, and that comes out to be the cancer at the T1 stage. So T1A is less than 5% of the resected segment. T1B is somehow greater than the 5% of the resected specimen, and T1C is involving the little bit part of the prostate. So if we talk about the T2, these are the different 2 lobes of the prostate, and it is involving, in T2A, there's involvement of the 1 lobe of the prostate. In T2B, there's involvement of the 2 lobes of the prostate. And in T3, the tumor, but you can see here that this is the capsule of the tumor, and in case of the T2 and T2A and B, the tumor cells are within the capsule of the prostate. But in T3, the tumor is actually spreading away, and it's breaching the capsule of the prostate here. And in case of the T4, this is extensive spread of the tumor involving the distant structure as well. So let me revise the staging for you, because this is something very important to know. T0 means that there's no tumor. T1 means that there is a tumor, but that's not evident. And whenever you are doing the TURP, and you're then sending this specimen for the biopsy, and the biopsy came out to be T1 stage of the prostatic cancer, and T1A, B, and C is if it's less than 5%, it's T1A, and if it's greater than 5%, that means it's T1B. In case of the T2A, the tumor is involving the one lobe of the prostate, and it is surrounded by the capsule. And in T2B, it's involving the both of the lobes of the prostate, but it's again within the capsule of the prostate. In T3, you can see here that the tumor is involving one lobe, but it's going out of the capsule, like it has bridged the basement membrane, the capsule of the prostate, and it's going to invade into the surrounding tissues. And T4 is a locally advanced tumor with invasion to the adjacent structures. So that's why TNM staging is very much important, to know the extent of the tumor, and then you plan the surgery. The removal of the prostate is the radical prostatectomy or the total prostatectomy, depends upon the TNM staging. What are the different kind of the clinical features? The clinical features are more related to the BPH. You cannot differentiate the tumor or the tumor from the benign prostatic hyperplasia on the basis of the clinical features. So again, because in case of the prostatic cancer, there's again the hyperplasia of the gland. This total size of the prostate is increased, and because of that, that's obstructing the prostatic part of the urethra, and because of that, there is bladder, and sometimes it's also affecting the or obstructing the neck of the bladder, and that will lead to the bladder outflow obstruction. Then there can be pelvic pain, because if there's a local invasion of the prostate into the surrounding structures, into the pelvic bones, there can be pelvic pain. There can be hematuria. Why hematuria? Because the prostatic cancer is actually there's enlargement of the gland, and it's compressing the prostatic part of the urethra, and because of that, there is actually rupture of the small capillaries that lead to the hematuria. But remember, in case of the prostatic cancer, the hematuria is a painless hematuria. In case of other complaints, like hematuria can be found out in urinary tract infections, right? And but in case of the urinary tract infections, the hematuria would be painful. But in case of the prostatic cancer, the hematuria is painless. There can be bony pain. Why bony pain? Because in case of the advanced tumors, the tumor is invading the part of the vertebral column or the ribs, so that can cause the pain. There can be malaise. Again, it's a finding of all the cancer. There can be arthritis. There can be anemia or pancytopenia. This is something very important to know. Whenever the malignant cancer cells or the metastatic cells are invading the bone marrow, so actually they replace the normal bone marrow cells which are responsible for the process of the hematopoiesis. So whenever there are malignant cells invading the bone marrow, there would be some kind of hindrance to the process of the hematopoiesis, and there would be formation of the different kinds of the invading metastatic cells, and that lead to the ineffective erythropoiesis, causing the anemia and the pancytopenia, because we know that all the precursors of the cells, either WBCs, RBCs, or the platelets and the macrophages, the actual cells which are responsible for their proliferation and their production, they're located in the bone marrow. And whenever the bone marrow is metastasized with the malignant cells, the normal cells are replaced, and because of that, the process of the erythropoiesis is affected. But there is another reason for the anemia, because we know that the prostatic cancer ultimately lead to the obstructive uropathy and the obstructive nephropathy. And whenever there is a obstruction to the flow, there's a back pressure on the kidneys, and ultimately the kidneys function start deteriorating. And we know that kidneys are responsible for the production of the erythropoietin, which is very much important in the production of the hemoglobin. So because of that, the decreased function of the kidneys, erythropoietin production is decreased and there would be anemia. So always keep in mind the symptoms of the prostatic cancer is somewhat related to the benign prostatic hyperplasia, like the bladder outflow obstruction. But the important thing here is like the patient will also will tell you about the weight loss. This is typical of the cancer. The look of the patient would be emaciated if it's advanced stage tumor, and he'll tell you about that. I have lost almost 10 to 15 kgs of the weight in the past 1.5 or 2 months. So this is something, and he will also tell you about anemia and the pancytopenia. So anemia and the pancytopenia, that's not usually a finding in the benign prostatic hyperplasia because there is no invasion to the vertebral column or the bone marrow. But in case of the prostatic cancers, there is a kind of the invasion, and because of that there is ineffective erythropoiesis, and there can be renal failure. I have already told you why renal failure, because there is increased backflow to the kidneys, and that actually causing a pressure over the kidney, and the function of the kidney is being compromised, leading to the renal failure. So you have to keep all these clinical features in your mind. Okay, so talking about the rectal examination, okay, the patient has given you up the history and telling you about all those symptoms which we discussed in the previous slide, and now you have to go for the examination. So first of all, starting from the general look of the patient, if there's advanced stage tumor, there would be weight loss and emaciated kind of the look of the patient, and then you have to start from the examination, start examining the general part of the general systemic examination, and then you go particularly to the digital rectal examination. So in case of the digital rectal examination, what you can find, actually you can go through the rectum and you can actually palpate the wall of the prostate, and you can actually palpate the surface of the prostate. In case of the benign prostatic hyperplasia, lobe of the prostate, you can palpate through the digital rectal examination, but the surface would be smooth. But if the surface is stony, hard, and nodular, you'll think about the prostatic cancer. And sometimes, in case of the invasion to the rectum, you can also feel the hard mass in the rectum as well when the tumor has already metastasized to or locally invaded to the rectum. So that's how you go for the digital rectal examination. The other thing which is very, very much important is a prostatic biopsy, and how you do this, the prostatic biopsy. You can see here in the diagram, this is the prostate, this is the bladder, and the trigone and the prostatic urethra. You can see that this is the anterior part of the anterior approach, and this is the posterior approach, and you can see the rectum here just behind the prostate, the bladder, the rectum, and there's a special needle for that, which is the transrectal needle. What you do is you push the needle anterior. You can go anteriorly, you can go posteriorly. If you're going anteriorly, you actually insert the transrectal needle and you take the biopsy. It's a kind of just like a true cut biopsy. You press the plunger and then it will take a kind of the small tissue of the prostate, and then you send this for the histopathology. And you can also make the posterior approach going to the posterior aspect. Now, this is something important to know. Why at the anterior and the posterior? Because we know that the prostatic cancers, they're mostly involving the posterior or the peripheral zone, and the BPH is involving the median lobe of the prostate. So if we go to the or insert the needle transrectally, you can go to the posterior surface, and you can directly go to the peripheral zone or the posterior zone of the prostate, and you can take the biopsy. There's another important thing, which is basically the prostate sensitive antigen. So there let me tell you that the normal limit for the prostatic cancer of the PSA, like the normal limit of the PSA, is 4 nanogram per deciliter. But if it is greater than 10, you will suspect prostatic cancer. And if it's greater than 31, it's absolutely sure that the patient, this value is absolutely telling you the diagnostic for the prostatic cancer. So if we talk about the serology, we have to start from the baseline investigation, general blood test. Why? Because if there's an advanced tumor, there's a bone marrow invasion, there can be pancytopenia in the blood CP, and you have to start from the general blood test, like the leukoerythroblastic anemia, because of the invasion of the bone marrow. There can be thrombocytopenia, and because of that, there can be intravascular coagulopathy. There can be increased fibrin degradation products. And then we also go for the liver function test. Why? Because this prostatic cancer also metastasized to the liver as well. So when there is a metastatic lesion of the liver actually arising from the prostate gland, ALP is basically raised, and if we talk about the prostate specific antigen, the level is usually 4 nanogram per milliliter. But if the PSA is greater than 10, then you will suspect about the cancer. And if it is greater than 35, you will think about, it would be diagnostic, and you'll think about the advanced prostatic cancer. So this is, serology is very much important. You always start from the baseline investigation, blood CP for pancytopenia, anemia, or the leukoerythroblastic picture. Then you go for the liver function test as well, LFTs like ALP, ALT, because whenever there's a metastasis to the liver function would be compromised and LFTs would be deranged. And the most, this prostate specific antigen is some kind of the less sensitivity, and it is less sensitive and less specific. There are other conditions as well in which the PSA is raised, but in case of the early tumors, PSA is not a very good prognostic index, because in case of the local or the early stage prostate cancers, PSA can be within the normal limit. But as a general rule, if the PSA levels are greater than 10, you'll suspect a cancer. And if it is greater than 35, it's a kind of a surety to the prostatic cancer, and it's almost greater than 35 in case of the advanced prostate cancers. Now, the most important thing when we have already done the non-invasive investigation, starting from the blood CP and LFTs and the prostate-specific antigen, what you do is you go for the radiological investigations, and you start from the ultrasound KUB and the prostate, and you also measure the pre-void and the post-void volume. In case of the ultrasound KUB, like the pelvis, and in case of the particularly about the prostate size, so ultrasound is giving you information about the prostatic size, and it's also be telling you about, and then you go for the PSA levels to differentiate the prostatic cancer from the benign prostatic hyperplasia. When you're done with the basic investigation and you have come up with ultrasonography, and actually there was a key point, enlarged prostate in the ultrasound, you go for the radiological examination. And in case of the radiological investigation, this is something very important. You go for the pelvic scan, you go for the X-ray spine, you go for the X-ray pelvis, AP and the lateral view, and you also go for the femur, X-rays of the femur. Why? Because these are the most common sites which are being metastasized by the prostatic cancer, and there are kind of the osteolytic lesions you can see here. These are the black osteolytic lesions which are found in case of the prostate cancer. The other important imaging is a cross-sectional imaging with the MRI. Now, if you are sure about the cancer and now you want to stage the cancer, you need some kind of other investigation as well, like the magnetic resonance imaging and the transrectal ultrasound. Because if the tumor is locally invading, there would be metastatic cells in the rectum as well. So you go for the transrectal ultrasonography. And there's another important thing, which is a cross-sectional MRI. MRI has got a very good sensitivity for the cancer cells and to pick up the cancer cells, where you can see here, these are the kidneys, and this is the prostate, and this is the prostatic cancer. So MRI is very much sensitive. You can see here that this is the cancer, and it's actually obstructing the prostatic urethra, and we know that it's obstructing the bladder neck as well, and the kidneys, some kind of the malignant cells you can find out to be in the kidneys and the seminal vesicle. So that's why MRI is very much important. Another thing is a transrectal ultrasound. Okay, so what you do is you put the probe through the rectum and you try to do the transrectal ultrasound. You can see here, this is the right and the left kidney, this is the urinary bladder, and this is the prostate gland, whole of the prostate gland. And you can see these microcalcifications. You can see here the prostatic cancer is, you can appreciate into the transrectal ultrasound. Now, this you should know that in case of the staging, the two important investigation to stage the cancer is the MRI and the transrectal ultrasound. So the transrectal ultrasound is actually going to help you with the staging of the tumor, like it's involving, it's less than 5%, it's greater than 5%, it's involving the rectum or not. So that's why transrectal ultrasonography is very much important. And at the end, the bone scan, because the prostatic cancer is notorious to get metastasized to the bones, and especially the lower lumbar vertebra, the ribs, the spine, and the pelvic bone as well. So you do a bone scan, and in bone scan you're actually scanning the whole of the vertebral column and the other common bones which are being metastasized by the prostate cancer. So you can see they're kind of the lytic lesions in the bone scan. So that's why bone scan is very much important for the metastatic. Now, if we particularly talk about you have through your history, clinical examination, and kind of the investigations, you have made a diagnosis of the prostatic cancer. Now, what are the treatment options we have available in case of the prostate? If we talk about the radical prostatectomy, like you always stage the cancer if it's an early stage cancer and it's an advanced stage cancer. So in the early stage cancer, only radical prostatectomy is sufficient. The only option you have is basically the it's not conservative, it's curative. But in case of the advanced tumors, the surgery can be palliative, and you combine it with the chemotherapy and the radiotherapy. So you can see here in the diagram how you actually do radical prostatectomy. So in case of the radical prostatectomy, whole of the prostate gland along with some part of the seminal vesicle is also removed. You can see here in the diagram, there's the rectum, there's the bladder, and this is actually the prostate gland. So what you do in a radical prostatectomy, that you actually remove this prostate gland, you separate the prostate from the bladder and the seminal vesicle, and then the prostate is removed, and the bladder and the prostatic part of the urethra, that's also removed. And this is the remaining of the prostatic urethra is again ligated with the bladder here in the picture. So this is about the radical prostatectomy, and in case of the early stage tumor, you do not go for the radio and the chemotherapy if the margins of the tumor are clear, because whole of the prostate is being removed, like in case of the T1 and the T2 staging, in which the tumor is actually within the lobe or within. You can also perform TURP in case of the early cancers, but transurethral resection of the prostate, you remove the lobe of the prostate, right? But in case of the older people, you actually take out the whole of the prostate gland, and there can be, you categorize the patient like low risk, intermediate risk, and the high risk patient. So the low risk patients are starting from the patients who are more younger. You took out the whole of the prostate, and the intermediate and the high risk. High risk are greater than the patients who have an age greater than 75. They're high risk patient, and those which have a age between 60 and 75, they are within the intermediate risk, and less than 60, they occupy low risk cancers, and always you go for the radical prostatectomy. So you can see there that there's a radical radiotherapy for all the prostate cancer as well, because sometimes the tumor is not that much invasive, and but since you're not sure about the margins of the cancer, so you, in case of the early prostatic cancer, you also put the patient on a radical radiotherapy. So there's another thing, which is the brachytherapy. In case of the brachytherapy, this is something very much important to know. You can see here in the diagram that this is the rectum, the bladder, and this is the prostate. And this is the catheter, which actually you insert. Brachytherapy is kind of the catheter, which is radioactive, and you leave that catheter in the prostate gland, and it keeps on emitting kind of the radioactive rays, and those radioactive rays actually destroy the cancerous cells. So this is the catheter, which is being inserted into the prostate, and it's a kind of the ultrasound guided, and you leave this radioactive catheter, and keeps on emitting radioactive waves, which keep on destroy the cancer cells. You can see this is ultrasound guided. So what you do, you put the ultrasound probe through the rectum, you go transrectally, and you insert the catheter, which is actually emitting the radioactive waves. And these radioactive waves actually, they keep on emitting and destroying the cancerous cells. So this is called as a brachytherapy, which is also an important treatment strategy. What we're going to do in case of the advanced disease, let me tell you, advanced diseases, tumors are those which are either metastasized to the liver or the bony part of the body, like the vertebral column or the ribs and the pelvic bones. So in case of the advanced diseases, what you do is you put the patient on a chemotherapy, you put the patient on a radiotherapy, or because the surgery is not curative, right? It's a palliative surgery. And what you do is you put the patient on pharmacological therapy as well, like the LNRH antagonist, luteinizing releasing hormone antagonist. You can see here, this is the pituitary gland, and actually this is the hypothalamus, and this is a pituitary gland. So hypothalamus is releasing the luteinizing hormone releasing hormone, and from the anterior pituitary, LH luteinizing hormone is released, and this LH is then acting on the testes, and it's releasing the testosterone. And in the presence of testosterone, there is a kind of stimulatory effect to the prostate, and more of the hyperplasia of the prostate is taking place. So what you're going to do is you block the root, and you actually give the LHRH antagonist. So these LHRH antagonists, they act on this, they actually block the release of the luteinizing hormone. In turn, the testosterone is not produced, and the influence of the testosterone on the prostate gland is limited or vanished. And you combine or you couple this treatment with the chemotherapy and the radiotherapy in case of the advanced disease. Another thing which is very much important, we know that in case of the metastatic lesions of the cancer is actually metastasizing into the testes and seminal vesicle as well. So if the tumor has invaded into the testes, you do the archidectomy. It's like you're removing both the testes. You can see here, these are the testicles, and you go through the skin, You give incision and you remove the part of the epididymis seminal vesicle, and actually this is the spermatic cord, and you give incision just like the incision in the inguinal hernia, the part of in case the incision is similar to the incision we give for the removal of the inguinal hernia. So what you do, you approach the spermatic cord, you separate the testes from the cord, and you remove it, which is called as archidectomy. And this is the treatment for those cancers which are already in advanced stages and they have already metastasized to the testicles. Okay, so this is a medical castration. The medical castration is also, I have already discussed, like the LHRH antagonists, which are actually, so what do you mean by the castration? The castration is, you can call it as the inability to produce the sperm. So whenever you're doing a medical castration, like the LHRH antagonist, so whenever the testosterone is not produced, obviously testes work and the prostate work under the influence of the testosterone. So you give a medical treatment in case of the advanced tumors. You also couple this with a chemotherapy and therapeutic agents like the abiraterone with a prednisone. You couple them up with the steroids, and you can also give the enzalutamide or doxetil with the prednisone, and other agents include the radium-223 and spicolacel T. And there can be other secondarily hormonal agents to actually antagonize the effect of the hormones. And the hormonal agent which is used as important is the ketoconazole, and you couple up with the corticosteroids. And there can be alternative chemotherapy like the cabazitaxel and metoxantrone, right? So these are kind of the chemotherapeutic agents, and this is a field to be dealt with, the oncology. But you just have to keep in mind the drugs which you're giving for the chemotherapy are like the arbiterone, you're coupling up with some kind of the steroids. And there's another important thing, which are the secondary hormonal agents, which are the ketoconazole, and you again couple them up with the steroids, and there can be other alternative chemotherapies. There's another thing which is very much important is a prostatic calculi. There are two kinds of the calculi in case of the prostate. One are the endogenous and other are the exogenous. The exogenous calculi, they're actually coming from the urinary tract. There can be calculus in the ureter, and then that calculus is slipped into the prostate. So they're the exogenous. And there's some kind of the other calculi as well. They are endogenous, and they are produced from from oxalates, right, and the phosphates. So but they are rare. And in case of the prostatic calculi, there's nothing much you have to do. The patient remains asymptomatic, and you leave the patient like this if a stone is like less than that. And if it's causing a lot of problems, the patient becomes symptomatic, you again do the prostatectomy. So in case of the prostatic calculi, there are some other treatment strategies as well, like the transurethral resection of the prostate. This is kind of the procedure we do normally with a resectoscope, and this is the prostate tissue, and with the help of this resectoscope, this prostate tissue is removed. It's a kind of the similar procedure we do in a benign prostatic hyperplasia, and we usually do it when the patient becomes symptomatic. Okay, so the other thing is a corpora amylacea, and these corpora amylacea, they're kind of the laminated bodies, and actually you can say that these are the precursor for the prostatic calculi, the endogenous prostatic calculi. You can see here in the picture, these are the lamellated bodies which are present in the prostate gland, and these corpora amylacea then later develop into the endogenous prostatic calculi. So if they are just the non-symptomatic, you don't kind of any kind of the surgery is needed. But if they become full-blown, develop into the endogenous stone, then you go for the transurethral resection of the prostate. So this was about the prostatic cancer. We have already discussed about the causative agents, pathophysiology, risk, and the treatment strategies. And at the end, we also discuss about the kind of the prostatic calculi, which are like the endogenous and exogenous. And we also discuss about the corpora amylacea. So this was all for today's lecture. And thank you for watching sqadia.com. Keep watching sqadia.com.